she was one of our first hires, and she was working, what's the dog company? We were her right hand person. So, yeah, we kind of stole her from there. And, well, I talked to her. It's the same. And pretty much the same for Jen.
Are we all set? I call the meeting of the Board of Health of November 5th to order. The first item on the agenda under new business is acceptance of the minutes of the meeting of October 1st, which are not yet available, so we are deferring the acceptance of the October 1st meeting minutes. The next item on the agenda is a discussion planned on the syringe service programs in the city of Lowell. And we have representatives from the Massachusetts Department of Public Health. And if they wouldn't mind just introducing themselves and just saying what bureau or what department they're from, that would be great.
Sure, I can start. Good evening, my name is Dawn Fukuda. I serve as an Assistant Commissioner and Director of the Bureau of Infectious Disease and Laboratory Sciences at DPH.
Hi, happy to be here. My name is Deirdre Calvert, and I am the Director of the Bureau of Substance Addiction Services for the Massachusetts Department of Public Health.
Hi, everybody. I'm Sarah Ruiz. I'm the Deputy Director of the Bureau of Substance Abuse.
Good evening. Hi, I'm Alex Wally. I'm the Medical Director of the Bureau of Substance Addiction Services.
Hello, I'm Casey Leon. I'm an epidemiologist in the Bureau of Substance Addiction Services.
Is that it? Okay, thank you. Thank you for coming. So I guess the board was, this topic has come up before the city council, and the board had a discussion at our last meeting about the issue around syringe service programs in the city of Lowell. We had a lot of questions in terms of the current syringe programs in the city. I think the councilors had some questions. We have some councilors that came tonight to hear the presentation. And so maybe if you could start with a brief presentation, and then whoever wants to could ask some questions.
All right. Is it okay if I use
Yes,
this?
please do.
Is this on?
It should be.
So it's a recorder mic, it doesn't protect your voice, just so that you.
Okay, I'm loud, so that's okay. So again, good evening, and my name is Dawn, and I'm terrible behind things. So just to start, my background, I've been in HIV and infectious disease work, including work with individuals who use drugs for over 30 years. I started as a case manager at the AIDS Action Committee of Massachusetts. So my heart, my head, and my soul is in this work, and I'm so thrilled that so many folks are here to hear this presentation. So,
Can you just hold the mic? They're coming to. Thank you, sorry.
like Oprah, I'll stand back here, it's okay. Unfortunately, I'm not able to project my slides, but you should all have copies of them. And so I'm not going to read them, but I'm going to ask that you kind of glance at them, and then I'll talk. The first point. Oh, yeah. Sorry. And maybe folks can share. I think I made about 20 copies, but it looks like we have more than that in the room. So the first point I'd like to make, and Dr. Alex Wally will follow me and do the second half of this presentation. The first point I just wanted to make is that harm reduction, as it is called, is part of a continuum of other services, other health promotion and disease prevention services for individuals who use drugs and others who engage in behaviors that could cause them harm. And so primary care is in that continuum, other evidence-based services, and recovery. I think one of the greatest sort of misunderstandings about harm reduction is that it doesn't include recovery, and it absolutely does. And it includes substance use disorder treatment and care. It just doesn't require that. And so it is a spectrum of services. It includes practical strategies to help people change their substance use in ways that reduces harm and promotes health, to reduce their substance use, to understand what kinds of drugs they may be putting into their body so they can make informed decisions about how much or how little or if at all they use them. Harm reduction recognizes that people who use drugs have autonomy and intelligence and the ability to make decisions when they have enough information and support to do so. The danger comes in for many people who use drugs when they don't have that additional support that they may need, or guidance from peers and compassionate providers. And, you know, we all kind of engage in harm reduction all the time in our day-to-day lives. Slide number 4, we use sunscreen so we don't get sunburn and reduce our risks for skin cancer. We think about how fast we drive, whether we're riding a bike or driving a car. We think about how many cigarettes we smoke, maybe choose to use cigarettes with filters versus those that don't. We engage in harm reduction all the time. Kids engage in harm reduction. They put on shin pads when they play soccer. You know, so it's not really as foreign a concept as people think. And if we can demystify it as much as possible, I hope that I and my colleagues can help to do that. So what about syringe service programs that are funded by DPH? So those are the only ones I'm going to speak to because those are the ones I know. We fund a number of syringe service programs across the state, and I kind of wish they were called something else. Yeah, they provide sterile injection equipment. And yes, they provide a mechanism for people to discard in a secure way the injection equipment they may have used. And they provide linkages to substance use disorder treatment and care, and primary care, and other medical care, and vein and wound care, and peer support, and connection to behavioral health services, and infectious disease testing, and. So many other things. I wish we called them drug user health homes. I wish that's what we called them. But for a variety of, they used to be called needle exchange programs, and we recognized that they were more than that, and that's when the language of syringe service programs came into play, right? So lots of good things happen at syringe service programs. That's what's captured on the slide on the bottom of page 2. And we could do more, but for, available resources. And the partnerships that these organizations are required under contract to have with community health centers, with safety net hospitals, with substance use disorder treatment providers, are what makes them a key component of the health and social service system for people who use drugs and people who love them. The programs top of page 3 are staffed not only by compassionate professionals, many of whom are in recovery, have experience working with individuals who use drugs, but healthcare providers, behavioral health providers, substance use disorder care providers. More and more, we are seeing integrated services because SSPs are partnering with places like community health centers and hospitals to offer a comprehensive set of services. What scares me most is in the context of the current administration, many of those organizations that rely on funding from places like HRSA and CDC are now being required to comply with executive orders that limit their ability to do things like harm reduction services. And so that puts us as DPH in a complicated position because we can't pay for the entire infrastructure that supports this work. And our partners who do this work so effectively are now also concerned. And I do worry about the downstream impacts that's going to have. There are currently 18 funded organizations that provide syringe service programs. They operate 72, these 18 organizations operate 72 syringe service programs across the Commonwealth, and there are 91 out of 351 cities and towns that have approved syringe service programs. Lowell was right there at the beginning, right, in terms of this network. And so we hope eventually to have this system be as statewide as it can possibly be, but we're not quite there yet. We have a website, that's what's at the bottom of page 3, slide 9, where people who are looking for the location of a syringe service program can find it on our SSP locator page. We don't think that may be used by people who use drugs. It's more often used by providers who serve them to try to find the closest place that folks can connect. And then I listed the agencies at the top of page 4, so you know who they are. I highlighted the ones that I know have served Lowell. Our colleagues from Health Innovations are in the room, from Lowell Community Health Center as well, and they do incredible work. And then there are other organizations not funded by DPH that I recognize are in the room as well that do really important work with this population. So I'm going to stop there. That's sort of from the DPH side, and I'm going to invite Dr. Alex Wally to come up and share some additional information about these interventions. Thank you, Alex.
And then we're going to take questions.
And then we're going to take questions. I can come back for questions. Yeah.
Okay, great. Thank you all so much for hosting us and the opportunity to talk about this topic. So I'm a HIV primary care doctor, and I'm also an addiction specialist. And what motivated me to become a doctor actually was the people that I met when I was a college student in Boston and Cambridge, who were using drugs and had HIV, and this was before 1996. So before 1996, HIV was a terminal illness. There was no cure. People were dying. Our hospitals were full of people who were dying from HIV, and this was a place where, as a physician, other healthcare worker, you could have a huge impact. I started medical school in 1996, which was the first year that highly active antiretroviral therapy was available. And that was a watershed year because HIV went from being a terminal illness to a chronic condition, which meant that people stopped dying from it. Except I was in Baltimore, and in Baltimore, people were still dying in the hospital from HIV. Most of those people were using drugs. And so access to HIV treatment was not available to people who were using drugs. They had to be clean for 6 months. Now, 30 years later, things are different, right? I take care of a lot of people who use drugs and have HIV, and none of them are dying from HIV. And that's because we're able to effectively get the medication needed to those folks. And what's even better is very few people, usually, who use drugs are getting HIV. And that's because of the treatment for substance use disorder, and it's also because of harm reduction. And those two things together worldwide are crucial. That's just some background that motivates me to be here tonight. So the first slide I wanted to show, what do syringe service programs do? This is a schematic from the CDC that came out during the first Trump administration in 2019. While I couldn't find, many of you may know that a lot of the CDC website is being dismantled, but you can actually find the words in this, but not the image, still on the CDC website. The headline here is scientists, including those at the CDC, have studied SSPs for more than 30 years and found that comprehensive SSPs benefit communities. And SSPs stand for syringe service programs. On the next slide, I'll get into some of the data in a little bit larger font so we can see it. So first of all, syringe distribution reduces HIV transmission. Not sometimes, not in a few cities, everywhere, across the world, across the United States. So this first citation is from a systematic review of systematic reviews, meaning that it's a compilation of many studies of many studies. And overall, SSPs reduce HIV transmission by 34% overall. However, in high quality SSPs, the reductions can be up to 58%. And the greatest benefits in these programs are those that have high coverage. High coverage means needles on demand, when people need them, where they need them. And also, as Dawn was mentioning, needles are not enough, and they shouldn't be enough. We want to couple the needle distribution with engaging folks, with giving them access to treatment, and for the other services that they need. And the one that is I've been working on the most, even with the city of Lowell through the Healing Community Study, is through the distribution of naloxone and overdose prevention. So in Massachusetts, we've had amazing progress over the last year with unprecedented reduction in overdose deaths. A lot of that is attributed to the distribution of naloxone, which Lowell is a leader in. However, I will say that the people most important for us to get naloxone to are the people who use drugs themselves. And the folks that have the best access to the people who use drugs themselves are the harm reduction programs. And as I've heard many harm reductionists say, they come for the needles and they leave for the naloxone. And so that's really an important key piece here. Next bullet. These are cost effective. Specifically in Baltimore and Philadelphia, there was a cost effectiveness study that found syringe service programs averted more than 12,000 HIV cases in those two cities over 10 years, with an estimated annual cost savings of more than $250 million. So it's not just the moral thing to do, but also the smart thing to do from a cost perspective. So to just drill down on some of the other outcomes which are important. So in a study done in Seattle, people who injected drugs who accessed syringe programs were 5 times more likely to start medication for opioid use disorder and 3 times more likely to stop using drugs altogether than people who injected drugs who did not access these programs. In Miami, public syringe litter decreased by 49% after the opening of a syringe distribution program. And one of the characteristics of syringe distribution programs that's important, that seems counterintuitive, but it has been shown in program after program, is these programs bring in more syringes than they put out. So the net benefit to a community of a syringe service program is actually reducing the number of syringes on the street. In Baltimore, there was no change in drug-related crime after the opening of a syringe program. So these programs are not designed to reduce crime, and but they also do not increase crime. Okay, so then I don't know how many folks here this next graph here is familiar, but this comes from a project that was done as an EpiAid. An EpiAid is when the CDC is called to ask to do an outbreak investigation. This was the one that was done in 2019 in the city of Lowell and Lawrence. And this just graphs the number of cases with the stacked bars there, and then the cumulative, that's per month, and then the cumulative number of cases with the dark line. So there were over 130 cases, new cases, diagnosed in Lawrence and Lowell between 2015 and 2018. This is not a cluster, this is an outbreak. The light blue bars indicate that it was related to injection drug use. So you see the vast majority of these HIV cases were related to injection drug use. And so if you look at this is the same data, the cumulative line, but sort of pointing out the sort of key responses that the cities of Lowell and Lawrence did in order to address this outbreak. And so it started with local clinicians reporting 5 HIV cases in August of 2016, and then a syringe service program opening in Lawrence, and then transmission clusters detected with HIV sequencing. So there was a whole bunch of science that was put into this that really tracked exactly how these HIV cases were connected, which was important. There were further increases in HIV diagnoses in people who injected drugs observed in Lawrence and Lowell. There's a clinical advisory issued by DPH. DPH convened stakeholders call. DPH convened a second stakeholders call, and then the privately funded SSP opened in Lowell, and that was in February of 2018. And then there was this intensive field investigation later in 2018. And you can see at the end there, the number of cumulative cases really starts to flatten off, and it has stayed flat for a lot of that time after the opening of the syringe service program, after the stakeholders coming together and instituting other, I'm going to skip 2 slides, actually 3 slides, other public health responses, right? So bringing the stakeholders together, the SSP in Lowell, HIV testing services, which were important, which weren't actually during the outbreak, reaching the emergency department, homeless shelters, and jails. And then we saw this substantial decrease in new cases. So just want to go back to one slide and talk about the people who were interviewed as part of this outbreak in Lawrence and Lowell. So of the 34 people who injected drugs, 20 reported injecting opioids, 4 stimulants, and 10 were injecting a combination of stimulants and opioids. 7 of them injected greater than 10 times per day. So this is one of the things that's different in our current era than it was 10 years ago. The injection frequency with fentanyl in the drug supply really pushes up the number of injections, and that has impacts on the number of syringes that are needed, and the risk of sharing syringes and sharing HIV. So that's really important. There was sexual behavior for both women and men that included exchanging sex for drugs, and that also drove this outbreak. All of the people who injected drugs and were interviewed had experienced homelessness within the past year. So Lowell actually has had a public health commitment to addressing HIV, to providing HIV treatment through its federally qualified health center and other medical providers, through its hospital. It has had, but the groups that really get lost in our without harm reduction are people who are struggling with housing, people who are injecting drugs, especially combination drug use, okay, and then commercial sex work. That group is really difficult, and the programs that are able to most effectively reach those folks are really the harm reduction programs. One last point I'll make, which is if you want to geek out on network epidemiology, is a slide before that has, I'm just going to point to it because you're probably not going to be able to see it, but the reference is there. Each dot is an individual person, and if they have a red dot, that means they got diagnosed with HIV. If they're a blue dot, that means they were HIV negative, and if they were a gray dot, that means they weren't actually tested. So despite all of that work that was done during the outbreak investigation, there's still people who don't get tested. And that means there's more work to do to reach those folks if we really want to completely control the epidemic. The other thing is that a black line represents an injection drug use transmission, and a red line is a sexual transmission. And you can see from this network diagram that there are mixings of the populations of people who get HIV from injection and those people who get it through sexual transmission. And so what that really means to me is that when there's transmission from injection drug use in the community, that impacts the entire community through sexual transmission, which will eventually happen. Okay, so you can tell I get excited about this stuff. Those are kind of the main things that I think we wanted to talk about, or interested to hear if there's comments or questions. Thank you.
Thanks, Bill. It says that it reduces the number of syringes found in the community, but the two statistics that are listed on our paperwork tonight from Health Innovations and Riverbend don't really show that. 48,000 were distributed by Riverbend and only 16,000 were collected. I'm not sure if you can comment. I know these are numbers here, they're just local numbers, they may represent whatever practices are happening, but I was
Yeah.
just wondering if you could talk about that.
Yeah, so the data that was reported there is the data that we get directly from an organization that we fund for syringe service programming. And so if an organization is giving out syringes, sterile syringes to their clients, those clients may discard them elsewhere. And so one of the other key pieces of data that we like to add in when we look at syringes discarded is those that show up in disposal kiosks. Because individuals, will dispose of them securely on their own often if they're not necessarily bringing them back to the program that gave them in the first place. So it's.
Do you have those numbers?
We do, and I could send them to Lisa afterwards. We do, and that's where the data that Dr. Wally referred to, where the ratio is, there are more discarded than there are given out.
So if you look down towards the bottom under where it says Lowell Community Health, it says it's also important to note there are 3 DPH-funded kiosks through the city. And it says estimated total syringes collected by weight FY25, 456,500. And then July and August. So that's just the kiosks that, and we didn't want to skew the numbers at the top.
I
So we
see.
put that down there.
Okay, thank you for pointing that out.
The city of Lowell actually has a kiosk as well, so those numbers aren't on here. And then there's a few other kiosks, and we also do the take back day as well.
And we still have to pick them up from the community too, with all the
Well, we
numbers that
do
we
have
have.
we do have the ones for the community, so
Yeah.
I did actually give you the numbers that, because we're specifically talking about parks and schools. So I did give you the numbers that are picked up for the parks from the schools as well. So I did give you specifically those numbers.
Oh, thank you, Lisa.
Yeah, so I gave you specifically those numbers through September. Yeah.
Still with that question, I guess my question would, to follow up with Kathleen said, was, with that discrepancy, what is the education for these people that, Riverbend is doing that? I mean, are we enforcing the idea that you gotta bring them back or bring them to a kiosk? Are they asking the clients? Are they bringing them somewhere safe, or are they just dumping them somewhere? Are we doing any auditing of what they're actually telling you they're doing?
Yeah, that's a fantastic question. So yes, when contract managers, who are the ones who are responsible both in the Bureau of Substance Addiction Services and in the Bureau of Infectious Disease and Laboratory Sciences, contact the organizations and ask them to demonstrate, like, show me the materials you're using in terms of education. Talk to me about how you're engaging people verbally and giving them this guidance. So you're right, the guidance includes both, here's a sort of individual-sized disposal container. Take this. Here's how you use it. Bring this back whenever you come in for services. And if you're not coming back in here for services because you can't or you don't want to or for whatever reason, here are your other mechanisms to safely and securely discard of your used injection equipment. And so absolutely, that's why I referenced there's so much that these programs do, and I wish we could hear from the programs directly so that they could talk about it, because they'll tell you precisely how they do this. And yes, DPH does hold our contracted providers accountable to do so. Thank you. Yeah.
So one thing that we had heard, can't remember if it was the council meeting, but that it's a 10-to-1. So if one needle is given out, or 10 needles are given out for every one that comes in. I understand that there's 10 that are put together to keep them sterile. Is there a correlation between those numbers? Like, I guess it's kind of the same question, but are we saying like, you have to bring one? Is there a wiggle room with there? Is it, like, for every
There's
one,
lots
do you
of
really get
wiggle
10,
room. So I'm
right?
going to say stuff that's going to get me in trouble, probably. So the point is to make sure people who inject drugs have enough syringes so that they never have to use one again and they never have to share one with anybody else. Right? And so we need to understand what kind of drugs is an individual using, how frequently do they inject, with whom are they also injecting. Often when we give an individual 10 syringes, they're giving those sterile needles to other people in their network. Again, so everybody is using a sterile syringe every time they inject. That's the goal. If we only gave people one syringe, that wouldn't happen. The sort of health outcomes that Dr. Wally reviewed would not happen. We would not have seen the reduction in new HIV and hepatitis C diagnoses that we saw. We wouldn't see people coming back because it wouldn't be worth their while. But they come back because they know we're going to give them a responsive number of syringes. And then there's opportunities to say, are you ready for a referral to treatment? Are you ready for a referral to care? Can we help you cure your hepatitis C? Can we help you get on HIV treatment so you won't transmit to others? So it's... Yeah, sorry, I get a little bit passionate. Yeah. But,
So,
Go ahead.
I was going to say, so maybe it's in here somewhere, but I'm curious, I assume that each of these entities also keeps track of, you list unique clients, but how many are returning, how many return regularly, and all those kinds of things?
yeah, we have client level data, yeah.
And what percentage of your unique clients actually return on more than one occasion?
I don't have that precise data to give you tonight, but I can get it
But
to
you
you.
do collect it,
Yeah, we
right.
do collect it, yeah.
So I just had a question for Health Innovations in Riverbend, and I'm not sure if they have this information. Are there there's talk about these programs giving vaccines or providing wound care, et cetera. Are those things happening in Lowell at either Riverbend or Health Innovations?
Yes, delighted to be here. And my name is Catherine O'Connor. I'm the Clinical Director of Health Innovations. And I have been in Lowell since 2016, officially as a funded program since 2018. So I have a very bad virus. We were one of the providers that Dawn referenced. May, would you mind passing my card around to everybody so that people know how to reach me and know the scope of our programming? Our work is provided on mobile health vans and also at 5 brick and mortar offices. So we were one of the providers that both Dawn and Dr. Wally referenced that started to notice on our mobile health van that we were identifying new infections. Like Dawn and Dr. Wally, I have been doing this work exclusively since 1988. I've been a practicing nurse. I'm in my 48th year of practice. And since 1988, I have been exclusively devoted to the care of people at risk for HIV. Based on the outbreak that happened that we just heard about, we were invited to open an office, and we've had an office at 205 Middlesex Avenue, Street rather, attached to the Lowell Transitional Shelter. And we provide mobile health programming at various sites, mostly the park, and have done that for years. When there were numerous encampments around the city, we would go and visit people and provide health care. And we are the drug user health center that Don Fukada just referenced, okay? So we are now, because of funding, for the first time in almost 25 years that we have been funded as an agency, we have experienced a cutback. It's the first time for us, and our programming has decreased from being in Lowell 3 days a week to 2 days a week. So we're open every Monday and every Wednesday. There is always a registered nurse present in the facility, in our office. We have on-site access to Better Life Partners who provide immediate, within an hour, I can have medication in a patient's hand if they want to address their opioid use disorder. I have a therapist on site on Monday and a lovely room upstairs over our 2-room office where people can have individual psychotherapy with a master's prepared social worker. And I have tonight 2 of our harm reductionists. Nikki's been with our program, Nicole Rossi, for 23 years. She's a skilled phlebotomist and outreach worker and in nursing school, certified medical assistant. May Sanchez, very young person, 21 years old, has been with the program since she's been 18. 20, okay, all right. She's, yeah, sorry, yeah, 24, okay. So she's been with us for 3 years. She's bilingual, bicultural. And as a young person, wanted to address what she was seeing in her own Latino community affected by substance use disorder. Any day that a patient comes into the office, they are offered syringe service programming, which is one thing in a huge toolbox that we have. Okay, we can immediately help people to access healthcare entitlements, Uber them to detox, or take them physically to detox if they don't want to go alone. Same-day methadone here in Lowell, okay? We work very closely with the methadone clinic, and if I call early in the morning, the patient will be dosed that day before the clinic closes. I address the mental health. I address access to substance use disorder. We work closely with independent nurse practitioner here, Jessica Wasaki, who is able to see patients pretty much same day or the next day, the Lowell Community Health Center, the Bridge Clinic, and we have had from the very beginning of this, of our tenure in Lowell, a very close relationship with the police, the co-op team. The whole team was out in Lowell today. We go to the park. We feed the patients every time we go with a packed lunch. We had a massive clothing drive today with an entire RV filled with boxes of clothes to distribute so people could have a shopping experience and get ready for the winter time with coats and clothing. Previously, we were provided with 7 free vaccines, as you just addressed. We no longer, because of cutbacks, are able to provide those vaccines. But in the history of our 25-year history, we have had access to those 7 vaccines. Most recently, we have been provided flu and Mpox vaccine, but in the past, we've had any preventative vaccine that you could imagine. We are able to provide pills on site if a patient would want to do that to prevent transmission of HIV. We have same-day access to pre-exposure prophylactic medication that a patient can take 1 pill every day and prevent transmission of HIV. Now, most of our patients, because of the chaotic lifestyle, and Dr. Wally eloquently discussed those patients that are at particular risk, and have, more challenges related to adherence. Most of those patients do better with injectable medication, both for treatment of their substance use disorder and also for prevention and treatment of their HIV. So our goal, I'm sure you've seen in the press that there's a new medication that's available where people can get an injection every 6 months, twice a year, and prevent transmission of HIV. Okay, that's been licensed and it hasn't been approved that I've heard of yet by Mass Health. And as soon as it does, I can assure you that we will be out there getting that medication into the patients' bodies that need it. So I've asked May to give you my card. Oh, patients have 24-hour access to our program. They can call us any time of the day or night. And very challenged patients never abuse that. It's a very, very interesting thing. Very, very marginalized, vulnerable people. They call us. They know they're going to get a registered nurse at the end of the phone. and they call us when they're sick and they don't know what to do, and they're really challenged. So I would love you to come and see us in our 2-room office attached to the Lowell shelter. I'd love you to come out on the van with us. It's a we have an RV that we've kind of turned into a makeshift medical van because we don't have any money, and we don't have enough money. We'd love to have a nice medical van that was a little bit more up to date, but we're doing just fine providing wraparound services, and I'm privileged to be here and care for your community members. I know it's very, very challenging to see young people and fellow community members affected by this terrible epidemic. The people that you were introduced to, including Dr. Wally and Don Fukada, myself, these wonderful young people, we're devoting our lives every day on the front line to stop this, okay? And it's terrible when you see people lying in the gutter and and using drugs. It's a trifecta of untreated mental illness and trauma in my 47 years of experience that then leads to the substance use disorder, which then leads to the bloodborne infection. And that's pretty much the story for every patient that we take care of every day. So I'll stop there, but please call me anytime. Come and visit us, take a ride on the van, and we can show you what we do. Thanks for having us tonight.
Thank you for coming.
Before you go, sorry, thank you for that. What? Oh, thank you, sorry. Just a quick question. So I think thank you, it's wonderful. I appreciate your devotion to the community and everything you're doing. Totally related to the services you provide. I think one of the concerns people have is, do these locations generate aggregation of substance abusers, drug dealers, violence, et cetera? So especially with your location, might be a little unique, but just, can you answer, like, are these places creating a focal point for violence and or crime?
Not the 5 brick and mortar offices that I have, that I supervise, and I would say now our programming is more localized to the Boston, Metro Boston area and North Shore. You can see the communities that we have offices in, but previous to that, we traveled from Springfield to Provincetown. We're a hybrid program. We're the only mobile health program that the Department of Public Health Bureau of Infectious Disease funds. And we have traveled all over the state to areas that are under-resourced, right? So we look at the science, as Dr. Wally referenced, that tells us where are the people that have the social challenges, that are experiencing the health disparities. So where we see people that, have unintended pregnancy, overdose, involvement with criminal justice, high rates of high school dropout, all of these, that's the kind of community where we started. Okay, we didn't go and park beside the Mass General, for example. Okay, we went to areas where people didn't have a lot of resources. Now, 30-something years later, many of the places that we went to have their own funding and their own programming. So I share this because I have been in pretty much every vulnerable, underserved community in the Commonwealth, and I have never experienced an episode of violence. There has never been, I have once had to move my van because there was a high school shooting in Dorchester within the block, and that has been the only exposure to violence that we have had. People comport themselves. It's very easy, right? You know what's going on there. You know what the services are. The patients understand that. They're either interested in what we have or they're not. Today, during the clothing drive, a lovely man had some nice, cool jazz music playing. Everybody was chilling out in the park. We enjoyed our lunch. The people were leaving with bags of clothes. Some people got on the van and participated in some testing. A couple of people were interested in being linked to food pantries because of food insecurity, as people are experiencing now with SNAP. It was a sunny day. And all of those people were drug users. No issue whatsoever. Because people recognize that we're bringing help and we're bringing health care. And so they don't want to do anything to disturb that. They don't want to do anything to upset that. They appreciate and they respect. Any issues in the office ever with a patient? No. So,
I just want to add, we got 2 people into detox today as well.
Thank you.
Thank you. I think we had some questions from the councils.
First, I mean, clearly, thank you all for the work you do. The difference here, I think, is between a municipality and the healthcare professionals. I think we share the same desired outcomes. I think, obviously, saving lives is first and foremost. I think providing treatment, absolutely. What I think is missed in all this discussion here is the balance that's on municipalities. Look at the cannabis industry, for example. When the state sanctioned the cannabis industry, dispensaries, retail, which is nowhere near what we're talking about here. A host community impact fee was imposed on that, where the host community that opted into that kind of medical ability, as they classified it, was able to charge off any additional impacts to the host community, which offset any expenditures that the taxpayers were burdened with. This is 200 times that. I mean, simple numbers. I mean, we see the numbers here on the sheet that was provided to us. South Common, North Common, other parks, schools, and then they add drop-offs and all that. That doesn't even touch the homeless encampments. I've personally worked in public works where we go out in the encampments and you have to use heavy equipment, and the city has to contract in special companies to remove the debris and soil because it's so contaminated with syringes, discarded syringes, and human waste, that this isn't even reflective on here. Just based on these numbers, now, I get it. It's reversed significantly the hepatitis and HIV problems that occurred widespread, nationwide. Worldwide, I should say. But just off these basic numbers, 49,000 unaccounted for off this sheet I'm working with. 5,000 syringes collected by 2 employees in the Lowell Health Department, which is footed by the taxpayers. So that leaves another 42,000 syringes out in public space that is unaccounted for. And I mean, the data can be all over the place. But at the end of the day, when you have families walking with children in locations where syringe, and it's syringe services now, initially it was syringe exchange program, it seems like we've gone away from the exchange and it's become a syringe distribution hub now, as well as crack pipes are being distributed in some of these hubs. And I don't know who's responsible. I'm not pointing fingers to what organizations are doing that. I understand it helps cut back on other types of communicable diseases, but the balance here is the municipalities are tasked with the aftermath, the debris, and we are the ones left fielding. Of a city of 120,000, if you have 2,000 people suffering from mental health and substance abuse issues, that leaves 118,000 that are forced, repeatedly forced, to deal with dirty syringes that are discarded in children's play spaces, in school grounds. I have irrigation specialists that then when they winterize in irrigation in the fields, they lift the cover, there's discarded, and that's no one in this room's fault. But that often gets overlooked in the pursuit of attacking and addressing the mental health challenges, substance abuse. And some of the things that is crazy to me is yes, you can put opioid medication in a patient's hand within an hour, which is great. But through none of this, is there any mechanism from the courts to the service providers to get people into treatment unless they voluntarily go? And now you're asking somebody that's not in the right mind, that is suffering from trauma, that is suffering from mental illness, that's suffering from substance use disorder, do you want help? Of course they don't want help, and it's few and far between once they do enter into the program, and then even worse, because of the lack of funding and the programming from the state, even if they do a 14-day detox program, they come out and they're let back into the environment which they came from. Even if they're lucky enough to get into a 30-day inpatient dual diagnosis, they're let back out into the environment which they came from. there's minimal or non-existent 6-month, 1-year programs where people have a realistic fighting chance at getting back on their feet with 24/7 access to wraparound services, retraining people to have regular sleep patterns, retraining people to have regular eating patterns, retraining people to fill out an application for whatever documentation they might need to get health insurance and all that. We're not doing that. It seems like the state has overlooked the let's give people a fighting chance model and said, how do we just manage and pacify the current crisis that we're dealing with? And I really do think through all of this, yes, we're seeing some positives, which is the reduction in HIV, the reduction in diseases, and all these other things that were mentioned today. But it's a heavy burden on local communities, especially gateway cities like Lowell, where we can't keep our head above water on this. I mean, we throw as many resources as possible, and all of this conversation really came from, we have to draw a boundary where these services can be provided to try to cut back on the exposure to children going to schools. I mean, there might not be acts of violence like was asked earlier, and no one's accusing that, but there are acts of violence when that van leaves. We're not talking about, people are acting unruly. There's people folded in half on sidewalks at 6:45 in the morning when a mother's walking down the street to bring her child to school. And people are blowing crack hits into the face of the child and the mother on their way to school. When you have a line of people that are intravenous drug users lined up 50 feet from a school when kids are getting released from school, those are the municipal's concerns. I mean, the work that you're doing is God's work, and no one's denying any of that. But there has to be a collaborative compromise here where we can protect the general public from the unintended consequences of all of this as well. And that's where I think this ordinance that we brought forward, that I think the council is gonna have no choice but to implement, is gonna come into play. So we can say it's gonna push it here, there, or everywhere, but at the end of the day, the 118,000 also have rights, needs, requirements, and boundaries that we need to respect, just like we do with those that need the services. So finding that balancing act and getting people in a room is a great first step, but realistically, I haven't heard one thing today that addresses the concerns of the general public as well.
Thank you. That was such helpful feedback, and so I've written down a few points in response. But I think what I want to start off with is I actually think we agree with the vast majority of things that you've just outlined. DPH does not want to see discarded syringes anywhere, let alone schools and parks and other public places that children and families congregate. And because we have contracts with syringe service programs and other providers, we can add resources, to the extent we have them, to increase cleanup services. So that's a mechanism we have. I completely agree with you. I think we all do at DPH and in the community. That should not fall exclusively on a municipality to do that cleanup work. So that, I said this to Lisa earlier, that I think may be a solvable problem. And I would love to continue those conversations about how we increase support for syringe pickup. 2, we agree that the system needs to be more responsive to the needs of people who use drugs. We agree that we need recovery supports and housing for people who use drugs so that we can optimize their chances to be successful. We agree that people are often set up for failure because the system does not have the capacity to give them the kinds of services that they require. And so I think, our colleagues from the Bureau of Substance Addiction Services are here. They can speak to sort of, I'd love to invite Dee or Sarah to come up and speak to sort of what they're doing in terms of strengthening the system of services for the very individuals that you've identified and that Alex talked about. I'm not going to speak to the ordinance because I'm not allowed to talk about political stuff because I'm a government person, right? And we agree that there are optimal places to site these programs, right? Spaces that are good for the community and good for the clients they're intended to serve. And I think that is a collaborative conversation that we would like to have with you all to figure out sort of how do we optimize that and make sure it's as safe as possible for the community, for families, and for the individuals who lean on these services. And the other, yeah.
The syringes. Now,
Yeah.
is this something, I did read a piece, and I don't know if it was real, not, you would definitely understand. Is there a type of syringe that can be distributed that's traceable through a barcode printed on the syringes. I know they have to be sterile, so it's not something that would be done on a distribution level. But is there a mechanism to order syringes so the city health department could track? So that way we can get some more data. So we can look at this and say, okay, out of all the sanctioned social service hubs or syringe hubs in the city, they're barcoded syringes.
Yeah.
So as they're being retrieved out in public areas, when we find out of 1,000 syringes collected in the past month, only 2 of them were barcoded from sanctioned distribution sites.
Right.
And so that we have a problem with other organizations coming in and distributing them. It will give us some kind of at least benchmark to be able to identify that.
Yeah, we have never done that. We have never sort of tagged them for a particular place. We know that people get their syringes from multiple locations, including pharmacies where they purchase them over the counter. And so it is not a strategy that we have employed.
Could I just ask a question?
Possible. I mean, anything's possible, but
So where do most folks who use IV drugs get their syringes?
I think from a combination of sources. So some of them come from the syringe service programs, some of them come from purchasing, some of them come from peers who might get them from different places. And so that's a piece of data. And I don't know, Tracy, I mean, we have an ethnographer in the room, who does qualitative research.
I would just say that it looks like last year, these two distributed a total of, it looks like about, let's say, 50,000, and yet we collected at least 460,000 syringes. So that should tell you the majority are not coming from these
exclusively,
sites.
right.
Well, if you believe those numbers.
Well,
The homeless camp, the encampment numbers aren't even included.
I'm going to believe that the distributed syringes that they gave us are the legitimate syringes.
Talking about the collective.
And that supposedly is the collected in the kiosks, right? That's the total collected in
And
kiosks.
by the city
And
kiosks.
the kiosks also factoring in diabetic residents that utilize.
True,
the kiosks.
true, that might be true.
That number's skewed. That's not what we're talking about here, because people, how many were in the kiosk again? What's the number on there?
465,000.
Those are responsible people that returned those syringes to a kiosk. And a lot of the times, when we're talking about substance abuse, that responsibility factor is just, realistically, how can you expect, or if you're not in the right state of mind and you're utilizing fentanyl, chances are you're not tracking down.
Yeah, listen, I'm not going to disagree with you at all, except for the fact that these people have to make an effort to come to this location to get them. So despite their situation, fog, and mental state,
I'm
they,
not asking where they get them. I'm saying from a municipality standpoint, our concern is where do they go once they get them?
Right.
And that's the fact that keeps getting overlooked.
right. No, and I like your idea about the barcode. I'm not even arguing with you. I agree with you. I'm just saying to you that the clients that come to these locations, this is why I asked about the repeats, especially if they're coming back routinely and seeking the services, they tend to be a more responsible person in general. They're less likely to just throw them out somewhere else. Back. They're more likely to actually bring them back and participate in that whole program. So I would love to see the barcode, but I agree with you. It'd be really good to know what's the net for these guys specifically.
When I go out into the encampments, which I have been for over 10 years, the clients that I see actually, when I come to their spot, they have their dirty needles in a bio shops container that we provided. So the only time I've ever seen a lot of discarded needles in an encampment is when the encampment was actually torn down.
Is that a low?
That's a moment.
Because I've worked in encampments where we found 6 biohazard containers that are completely empty, but yet you move a mattress off the ground, and there's a few hundred discarded syringes under that one mattress, times 15 mattresses and couches and everything else.
We're losing control of this meeting. Okay.
To ensure and transport what we could before we could go in and remove it. And immediately, once we were given the green light to remove it, it was to the point where we had to bring heavy equipment. So, I mean, it's you can't tell me that people are getting high and just tracking down. Yes, while they're maybe getting ready to get high, they're of a better state of mind. They know that van pulls up, they can go get clean syringes. syringes, it's part of the process. But after the usage is the problem that the municipalities are challenged with, just as well as you all. Because I'm sure you deal with clients that you see, after using, it's a completely different person. And the discussions around treatment and all that, they kind of have to wait till that brain fog kind of subsides before you could even begin and pick up where you left off.
Okay.
Could you just go, because otherwise it won't be recorded. Sorry.
Hi, I'm Tracy Green. I'm an epidemiologist, and I study public health and overdose. In 2017, I was here prior to the outbreak, or the announcement of CDC's EpiAid with the state, and we were doing surveys and interviews with people who use drugs in August of that time, all around. And we didn't know that fentanyl had set in the community, but as we talked with people, they were very upset about how the experiences they were having, the overdoses that they were seeing, the unusual experiences that they were having, how many times a day they had to inject, how many times they had to reuse, and being really unsure of where to discard them. The syringes, when they were, if they could get them, it's very expensive. They'd have to go to CVS and purchase, injecting 10 times a day or more commonly for people who are using fentanyl means 3,650 syringes potentially every day, because it's an everyday activity. And that was $3.50 for a 10-pack at CVS on Bridge Street every single time. It was a lot of expense. I actually worked with CVS to look at how many syringes were sold and dispensed, and one of the largest distributors, not just because CVS actually started here in Lowell, but was actually in this community. Communities that didn't have syringe service programs really were sourcing, people would have to purchase and then reuse. It did make it even harder on people because they stressed out about where they were going to put the syringes. They did not want people in their community and kids and others in the community to access them, so they would work hard to break off the tips or throw it away. And this is, as you're kind of talking about, kind of contrary to what this is a high level of organization that's required to think about, okay, every single one, 10 a day, I'm going to take this off and make sure, and where am I going to throw it, and I don't want to get in trouble. And it really was like a daily affair of trying to figure out how to take care of their community in addition to the health condition that they had. We did see at that time the only two places that you could dispose of your syringes were the senior center and the dump. Both of those were really hard. Thank God, talking with people at BSAS and at Biddles around this, the disposal containers were started to be brought into the city, and they filled up really fast because people finally had, if you build a trash can, people will actually use the trash can. They don't want to carry around their trash worried about where they're going to put things, especially if you have an HIV transmission potential associated with it. But those were surveys, but they were also talking with people about what their experiences were, and each layer, as Alex shared, and you've heard, each layer of responses from this community and from the services from the state that layered on, and amazing clinicians and providers that have added to, have calmed down. So I wouldn't be surprised if some of the archival trash that you're seeing in the disposal might actually be many years of syringes that have been there because there hasn't been syringe access and disposal that's been sufficient. So and with nowhere else for it to go, the river and the trash spaces in the city are very likely to have been the accumulation. So I don't know if this is helpful to kind of reflect a little bit more. Like you're getting, it's like a geology project. It's like every layer. It's like you're looking at the syringes from the 80s, syringes from the 90s, and so forth.
Yes, as was mentioned earlier, abandoned encampment, absolutely. I have a friend that owns a business on the corner right by the South Common, the barbecue place. 10 to 12 discarded syringes daily in the parking lot. That's not archived.
Great place for a disposal unit for somewhere around there.
And it's private property, though. So now,
Finding a municipal space that might work. But one other thing, you were a budding epidemiologist yourself, because that syringe marking idea actually was what my dissertation advisor did at Yale, and he actually did that in New Haven. And those data, by marking the syringes that went from a syringe service program in New Haven, compared to the ones that came from not from the syringe service program, he's a pharmacologist and was able to pull out and extract HIV from those syringes, and he actually proved that syringe service programs effectively reduce HIV transmission because the amount of time that HIV is live in that syringe that came from the syringe service program was less than that sourced from anywhere else, because they come back. People come back and they bring their syringes back. So it shows, you're very, very perceptive and right on. So.
No, so maybe that's
But
something
it was
that
an
we
expensive
both
study.
benefit
Don't do
from.
it.
Yeah,
You don't
absolutely.
have to redo it. But it did, you're right on.
Thank you.
Thank you, Madam Chair. And for starters, I'd like to thank all the representatives from the Commonwealth for taking their time being here tonight. Your efforts are greatly appreciated. And I understand full well, your mission is to prevent infectious diseases. I get it, and I supported it. I'll give you, and to the outreach workers that do all the layman's work, the boots on the ground, thank you very much for what you do. But to tell you a little bit about myself, I was chairman right here in this room since 2014, along with my good friend and colleague, Councilor Mercia, on the opioid task force, right, that we, since its inception in 2014. We did a lot of great things. We were the first in many, many areas, along as the first one to have a needle exchange, which I will get into. The first to bring technology in this fight. We brought the ComStat program to monitor overdoses all around the city. We brought that. We were the second ones in the Commonwealth to emulate Gloucester's Angel program, if we can all go back that far. We were the second one to incorporate an outreach team, including one full-time police officer, firefighter, in Trinity EMS, our ambulance provider, also provided a full-time employee. So no one is going to question Lowell's commitment to this issue. However, now, if we can rewind back to 2016, that was mentioned earlier, where, we got a presentation that there's been an outbreak in Lowell and Lawrence. And I think, and I had this nice discussion with Councilor Mercier on this. I remember full well that, we need a needle exchange program to prevent infectious diseases. So, as chair, I'm hemming and hawing. I'll be honest. I ended up supporting it, but I'll tell you what I supported, and I'll tell you where we are now. I supported a standalone facility, needle exchange 1-for-1. That's what I supported. Not a mobile van driving all over near schools and parks and handing out bundles of 10. And I'm out in the street too. I want to link with my colleagues. I'm walking homeless encampments at all hours of the days in the neighborhoods that I typically don't represent, but that's fine. And I'm told, no questions asked. Check bundle, one bundle, two bundle, here you go. And what do we end up with? At this point, in 2025, 2 full-time needle syringe coordinators to pick them all up. And we're not even getting all of them. 2/3 of them are still out in the rivers, streams, parks. Who knows? I was also a downtown businessman from 2001 to 2016. I've seen this crisis skyrocket. I've lived it. I know it well. And I'm frustrated, as you can see, because we're sitting here tonight talking about the same problems, and we're getting nowhere. This harm reduction approach, people, I know we're all doing good work. It's not working. Okay? You all represent the Commonwealth. This may not be popular with all of you, but I'm going to say what needs to be said. It is time for involuntary treatment for these people. You may save their life. Giving them needles, letting them back out in the street to reuse is not helping them. But that's what needs to be done here. So this program, this syringe program, to me is on watch. I'm at this point inclined to abolish it. I really am. And I'm sticking by what the council approved, 1,000 feet from schools, and I'm not budging so much as an inch. I've seen too much carnage, people. I'm sorry, but I've seen businesses fail in our downtown, which has become a mass graveyard for small businesses. I've seen many residents talk to residents in their homes, in their neighborhoods. Their quality of life has deteriorated. And you all have seen it too. And those are people we represent. And that's what's happening with this crisis. It really is. Is it largely responsible for the needle exchange? No. But it's not helping. So I am of the opinion that this program is not helping. It's more detriment to the city at this time than it is helpful. So, by all means.
I've been
working on the streets every day, Monday to Friday, with our community, I have seen the drug changes. I've been a nurse 16 years, worked in addiction treatment 10 years. I have worked from detox to MAT to the streets of Lowell the past 4.5 years. I have witnessed with my own eyes the reduction in needles in the encampments on the streets. It is truly come for a walk and see the changes. There are so many changes, and it's beautiful. We've seen people get into treatment and do really well over the years. What we've been able to do with our clients has been incredible and beautiful to see. We have people get treatment. They choose treatment, though. We don't force treatment, and that's when it really sticks with people, is when they can choose for themselves where they are at in their journey. And body autonomy, their own choice, is such a, really, it's what we're here in America for, is to have choice over our journeys. Harm reduction is taking our opinions out of where we think people need to be and allowing to help, yet be there to help people where they're at. As a nurse in the field, I see it every day. People get help. I have helped people in such beautiful ways. I have seen people get and maintain recovery. I get messages from years ago from clients reaching out, thanking me. Just, I may not even remember them, but just being there and providing them with some like hand hygiene products and a moment to just allow them to talk about their problems. That's what some people need, and that's what we provide. It's not just about the syringes, and I have seen a reduction firsthand in the syringes on the streets and the encampments. I am out there Monday to Friday. I bring a backpack out, I'm out with vans, I'm out with outreach workers. We help people with housing. We help people in so many ways, but there is a huge difference with the program. From the 4.5 years I've been on the streets in Lowell, really Monday to Friday, I have seen amazing differences. If we were to take this program away, we're gonna step backwards hugely, and it's really heartbreaking to think that we could do that to our community, and a bit terrifying, honestly. Having seen the differences in the community, really, I am out there Monday to Friday. I welcome anyone to come with me. The program's amazing. I am so grateful for Health Innovations and for everyone supporting us, because I've seen the changes. I walk side by side with our clients. It's a needed program. I can't imagine if we take it.
Well, thank you very much for speaking, and I could see your commitment, and you're hurting for this population. I could see it on you, and I appreciate your compassion and support for this population, okay? But the numbers show differently, ma'am, okay? We're still picking up a large, extremely large quantity of needles. That is not reducing, despite what you're telling me, okay? Just in the last calendar year, we've had 2 to 3 businesses petition the city council on this issue. They're not seeing improvement. We had all residents, many, many residents, including the Lowell Housing Authority, South Common, which is the ground zero for the city, petition the city council. Many, many problems there. The city has 15 to 18,000 arrests this calendar year because of this issue. Not to mention the numerous taxpayer resources that we put in with the co-op team, our police, fire, outreach workers, our health department. Millions of dollars are spent by the Lowell taxpayer alone on this issue. I'm sorry, but we're not seeing the results that you're indicating. Now, although some people are taking help, yes, I understand that. You're getting people every day, like some people, but a significant higher percentage are not accepting the help. And I can't allow them to take the city down with them and in our neighborhoods and our businesses at the same time. So I appreciate where you're coming from. I hope you can understand where I'm coming from as a representative of the city and the residents. So, go ahead, Joanne. Go ahead.
So a lot of the increase of the numbers that we had seen over the last year from Andres and Tom had picked up was from the encampment cleanups, but a lot of it was from when we cleaned up along the Merrimack River from Sheehy Park. And a lot of what we have been seeing is what you had said, from when it rains, the needles are picked up from the soil. And that's why Andres and Tom continue to go through, and they're picked up from the soil. So every time it rains or at the end of the winter, they raise up through the soil. So we're picking up needles from years and years ago, and that's why it continues to raise up. I don't think we had ever had a cleanup along the river from Sheehy, from that far, from Sheehy Park all the way down to the Rourke Bridge. We had never done a cleanup that big in, I don't know how long. And that was the bulk of what we had picked up, and that was why our needle count was so high. And they continue to go down there and do that. And that was a large amount of the needles that they had picked up. And when you look at what we picked up, there was a 75% decrease in the needles that were picked up on South Common from the last year. So we don't want any needles anywhere, but there has been a 75% decrease. And right now, we are giving a bad name to the van that's picked up on the South Common, but there was a 75% decrease in so they are doing a better job from South Common. If you look at the paper, from FY '24, from the year '24 to '25. So they are doing a better job. When you're saying putting them on watch, they are doing a better job on what they're doing. And because last year Andres picked up 3617, and this year he picked up 709. A lot of the needles of what he's picking up, I spoke to him the other day, a lot of the needles he's picking up right now is because LPD is doing arrests on South Common, and they're having people empty their pockets and drop the needles, and he's coming and picking them up in the morning. And that's the reason that the needles are being left.
Lisa, you're doing great work. The needle change 4 days, please. I don't
Right, but I'm letting you know why the needles are
But you just
increasing
discredited
in the
everything
area
you
that
said.
Corey was talking about, because the needles are being left there for Andres to pick up in the morning. So I'm letting you know why the needles are being left.
I think there's no doubt that people with substance abuse require this kind of care, in my mind. However, there's also no doubt that the citizens of the city are also experiencing some harm from this epidemic as well. And I don't think going back and forth about that really is going to be as helpful as perhaps thinking about how we can offer these services and increase help with picking up the needles. I myself picked up a needle in the parking lot of Demoulas just the other day. I mean, these are not just from the 1980s. I don't agree with that. I think that's maybe dismissive, not intentionally, but this is a real concern for people. We experience it every day living here. That doesn't mean we're not willing to or on board with the help that you all provide, because that's not true. Right. However, there has to be mitigation for those concerns as well, in order for people to be able to rally behind these people who so desperately need the support here in the city.
So, go ahead.
There you go.
So I think there's two things that need to be looked at in further discussion down the road is getting some syringe cleanup support from the state health department, and also needing to look at optimal place siting. And so the councilors have ideas of what they see as optimal place siting, and I think that there can be some compromise about where the residents of Lowell or the administration, what sites they prefer not to see this particular service happen. I think that we can find a compromise in terms of those two things. And those are, I think, two of the most important things we need to look at is help with the cleanup. I personally feel that syringe programs are important to the overall health of the people, those folks that are being served there. I think that before tonight, a lot of people were under the impression that they were sites that distributed syringes and didn't do a whole lot else. I can remember fighting the fight about condoms in the high school clinic and people being against that and talking about, yes, you can't get hurt by a condom that you find used in the park, but it sort of goes back to the whole public health idea and the need to provide, it's part of the, we need to provide Narcan to folks. Probably one of the most important things you do is provide Narcan to folks. And so I think those are two important things that we need to be in the follow-up conversation is syringe cleanup help from Mass DPH and finding a compromise of where these services which are needed, I feel, can be cited in the city. And I think my colleague Kathleen is correct. It's legitimate concerns when you take a child to a park and there are syringes there. But I don't think that means that we have to eliminate this program, because I think there are things that can be worked out and things that can be done without eliminating the program.
Can-
Never want to put the community as a whole in a position where we get behind the eight ball on communicable diseases. I think there's been way too much investment and work from human equity, funding and resources to ever even consider abolishing something like this, but it's again, as the young woman nurse spoke about, people, yes, I agree. People have a right to do free will, to do what they want. But at the same time, with any of us, our free will, when it begins to negatively impact others, that's where the conversation has to begin. And that's where we need to find that common ground that we can coexist. We're looking for a coexistence point that minimizes the impacts to the general public and still provides the resources and services to those that need it. And that's really what all of this is about. And I think working with professionals in the room, as we've met tonight, we'll find that happy medium. It's just a matter of having these difficult conversations in some instances and trying to be rational about it. So, again, I thank you all for
If I could just
presenting.
take 1 minute. So I'm the director of the Bureau of Substance Addiction Services. So just to, two quick points that I'd like to point out just to the comments. And I just want to say thank you because we really appreciate all the feedback. Is one thing that we haven't discussed is the 38% decrease in overdose deaths that the state has seen because of harm reduction efforts, and that includes Lowell. The second thing I would ask for people to do is go on our DPH dashboard and look at Lowell, and you can see how many people went to treatment, how much naloxone was distributed, how many people actually went into the sober homes or to any of the programs that we do, and you can actually see where treatment is actually in action, and you can see those things. Happy to give you those numbers, but you can tool around there and see all of those things. So that's really important. You can look at it.
Before you leave,
DPH. I know. How can we help advocate for the missing pieces in the chain of recovery? Like, if it's something that, as a local council, Springfield, we have our solicitors been in contact with Springfield solicitor. I mean, if it's something like a home rule petition or we have to put forward something requesting, how do we find that missing piece that helps facilitate that compromise or whatever's not there now? We need to figure out how can we help you and how can you help us and help the entire community together.
Yeah, you can see from the amount of people that are here from DPH that we're here to have that conversation. So we would be really, really happy to continue those conversations from the treatment and recovery side, talking about our peer recovery support centers, talking about our long-term 24-hour withdrawal management, our step-down services, our, all of the treatment that we have, the MOUD, happy to our Biddles colleagues who oversee the syringe programs. All of that, you've got a lot of people here who are really willing to helping you look at what your municipality money from the opiate remediation funds are, how to use those funds in an equitable way to maybe ensure that you can get even more supports, how to get matching funds particularly from RISE grants to also help mitigate some of these things. These are all things that we're really happy to work with you on, and we've got lots of TA and technical assistance. Again, you can look at our dashboard, which is publicly available on mass.gov, and you can see all the things that are happening in Lowell, how much money you're getting, how much the naloxone's being distributed, how many people are actually accessing treatment. So it's a really good resource. But we're here. You've got a lot of people here who want to help.
before you step out, just the comment was made about involuntary treatment. Can you just make a quick comment about that for them?
Yes, I can.
Doesn't work. Right, just want to hear.
That's a quick comment, doesn't work.
It actually, their civil commitment does not work. We have data that shows that outcomes that show that people who go to civil commitment who are forced against their will have poorer outcomes. They are more risk for all-cause mortality. They're more risk for fatal and non-fatal overdose deaths. And what happens is that just for what happens is a warrant is sent out by a family member or something like that. You've got 5 days that warrant is active, which also mitigates the fact that that's not a crisis. If we're waiting 5 days, that person is picked up, they are shackled, they are put in the back of a police car, and they're taken to court. And a judge is determining whether or not they meet the criteria for substance use treatment. And then they are put somewhere for up to 90 days. If you are mentally ill, it is 72 business hours, and you can revert to voluntary. The risks, the people who are tentatively tethered to community is all lost. If you are tentatively working, if you have a job, if you are trying to get back active with your kids, and you don't even actually have to be actively using to be civilly committed. You're supposed to be, but people think you are at risk for relapse. We can do that. We have over 6,000 commitments each year. We have 4,000 people who are committed. We have lots of data that shows that it actually is harmful and that we should be investing our money in voluntary treatment that actually works, in voluntary treatment that provides those aftercare services that you say are missing. BSAS is spending, the Bureau of Substance Addiction Services, out of pocket, is spending more than $16 million a year to keep people civilly committed. Do you know what we could do with $16 million a year? For $12 million a year, BSAS has actually housed permanently 600 individuals where they are permanently housed with wraparound services. We would like to invest more money in that than keeping them in a service that they might actually die from.
Can I just ask?
Thank you.
Thank you.
So we're worried about the effect of mandated treatment, but Massachusetts has more mandated treatment per person than any other state. So it is actually something that is already occurring in our state in every courthouse. And so if you want to double down on mandated treatment, something we don't think works, first, it's super expensive and it's temporary. So Massachusetts has the longest mandatory term of any state also, 90 days. Now, the average is less than that, and that's determined by the judges. But we're already doing mandated treatment, and it's not working, and it's temporary, and it's expensive. So if there's some magic money machine out there, we could, but we're already doing it. Like it's the only way you can get treatment on demand in Massachusetts. Well, I'm not gonna say that. It is one way to get treatment on demand in Massachusetts. You can't. The people who get mandated to treatment don't get refused from treatment, and that goes on the taxpayer's bill. We're all paying for that, and it's way less efficient than voluntary treatment, and doesn't work as well.
Thank you. There was, I think, Councilor Getchia.
I don't know how we went around the bush like this, but we've gone far away. This community spent over $10 million in opera funding trying to help people. No other community in the area has done that. We sit here and we get calls every day, and you guys are the professionals. I agreed. I supported everything that you guys got from the city, if any of you got any funding from the city during the opera program stuff. When we look at what we get, when you have a video of people handing out needles in the South Common parking lot, the person walks over and offers somebody sex as they're walking up with their young child, we got a major problem. You go up to the playground and a person has their pants down around their ankles going number 2 in their playground, and the needle is right there. We got a problem. When you start looking at all of it, I don't think it's irrational to say 1,000 feet from a school. And I don't know what you think or you don't think. I don't know. But a designed place for them to go that isn't within that area, I don't see as much of an issue from anybody on this board. But I can tell you right now, I don't see anybody on this panel here, or probably in the city council, who's going to move on that. We were told stay in our lane. Since 2016, we've been in that lane. And it hasn't changed. We haven't seen one thing come from anybody asking this board since I've been there to let's discuss this. So it came from this board, this conversation, not from anybody else. We had to get out of our lane to get the conversation and try to see how can we fix an issue around our schools. We talk about mental health all the time. What do you think happens to a child who's walking to a school with his father and he's offered sex in front of their child? Or what do you think happens to a child when he watches someone have a needle in their arm on the way and the father's trying to hide it? Or that child who doesn't get busing to that school and has to walk through that environment. When we look at the South Common numbers, they only went down because we moved the tenting. They're on Charles Street. And if anybody in here doesn't know what Charles Street is, I will take them tonight and we will go down there and I will watch people shoot up in front of us, in front of Vinfin, and I'll show you where they discard their needles. Council Belanger and I walked it. Councilor Robinson and I walked it. We watched it right in front of us. And you can smile because it's the truth. We can smile back and forth because you're going to go to your lovely community that is in Lowell and you're going to have a good night's sleep and not have to deal with this. But this is real, and it's on the low-income people. It is not on me. It's not in my neighborhood. It's not in any one of the people's here neighborhood. I live next to Sheehy Park, and many a times, my wife is here, you could walk out and see a needle on the ground. But it's real. And it's the people who have the least who are in this environment, and we're sitting here saying, enough is enough. We need your help. We've had your help. And we're sitting here saying that to the health board. We need your help. Whatever the understanding, whatever the, and I thank you, Mrs. Keegan, for pushing this conversation, because I think it is a good conversation. I think there is a happy medium somewhere. But I don't see us moving on the school piece.
So as one of the people that, I didn't make the comment, but I was right, well, I agree with it. So
Well, I read it in the newspaper. It was from me. So if you didn't make the comment, I think you should call the editor and tell them
Yeah, I
that
know,
they're starting a
everybody
fight
said
back and forth.
It's so futile.
Anyway,
Yeah.
I don't,
And the Lowell Sun doesn't ever quote people right anyway, so I agree with you.
I don't disagree with anything you said, and I feel your frustration with the substance abuse problem in Lowell. We all agree with it. I'm a physician here. I take care of patients. I see it every day too. I feel your pain. It has nothing to do with what these guys are doing.
No, and that's what I didn't understand this whole
I just want
conversation.
to make it clear. It has nothing to do with what they're here. It's too late. By the time they're coming to see these guys, they're already using. It's too late. I hear your issue about syringes, and if they're giving out 20,000 syringes more than used to be in Lowell, then that'd be a concern. I don't think it's true, but if that's, we should be able to prove it to you. So I do agree with that. On the issue of location, my only concern is it was brought to us that this 1,000 feet from parks and schools means there's like 2 little square feet of Lowell where they can actually put these places. It is important that these places be somewhere that the people who want their help can actually get to it. And so the compromise I'm looking for is it's 1,000 feet, we're not gonna compromise. Let's find a place that makes the most sense,
Right.
where they can actually help the people, but not be in a school playground.
I think there was a compromise, because we didn't say anything about parks right now. So there is a compromise right now. And the funny thing is, a cigarette on the ground has no comparison to a needle. But that's what was discussed. It has no comparison when you're a 5-year-old kid or a 7-year-old kid in a playground next to your school, where we have videos of it from parents. So, and what we're saying is, look, from 2000, I think it was 16, you said, to today, there's been no discussion. And the needle, whether it's increased or decreased, and I probably agree, it probably has gone down, because I think Lowell has done an extreme job on this. We talked about detox and how many people have went to detox since June. I think that was amazing. I think it was 68 or there's a high number. I think that's amazing when you looked at, when we first started, less than 3.5 years ago at this whole thing, we had 301 homeless people here. Just the last count was 210. And from that last count, I believe it went down somewhere, 68 were detox pieces, and then it's moving because it's summertime, and now we're coming out, and you'll see different numbers. But I think we did a lot for a lot of people, and it's because of your hard work, not ours. We just set a policy, and you have to deliver on it. And I do agree with the health board is that this needs to be a much stronger conversation than, okay, here it is. And I think that you have moved the pendulum. We looked at the parks, a lot of us, and we're just saying we need to do something with the schools right now. The schools are something right now, and let's see how the program works from that piece and go from there. Whether it's 1,000 feet, whether it's, it has to be 1,000 to include that South common park where they're dropping right there and they're driving through. And I think the mobile unit should be removed from the city. And it should be at a fixed location. And you come, you get, you go. I think the mobile unit just creates a lot of barriers that we can't contain and we can't police, we can't do anything with, we can't oversee, so.
Are you talking about just the syringe piece from the mobile?
Yeah, it's just a syringe piece from the mobile. Yeah, it's not the health services.
Just the syringe
Handout.
all the other.
Because we've been told that it's not even groups that are from the city, it's just another group dropping them off and going.
So, Counselor, you had one motion, which was just the schools, but then there was a second motion that was schools and parks. So there are two different motions.
So it got amended to the parks, but we can certainly go back on the parks and move that piece if that's the piece that's the hold up here for now.
So I guess I'll refer to the,
And that's really what we were thinking is that piece.
and I don't know if
We-
we look at it, if it's just the schools, if that excludes everything.
It comes back to the council and we just we just kick it back for another hearing.
Yeah, so nothing was actually passed. It was just a motion to draft an ordinance. So nothing's been drafted or approved that way. What came to me was 1,000 feet from schools and from parks. There's a lot that goes into it, but 1,000 feet from schools and parks, as someone alluded to, will pretty much cover the entire city, which, the SJC has, and actually in this packet, someone referenced the case in one of the handouts, which I appreciated because I had already read the case, so it was nice to see that. We can't ban them outright, but to put in a buffer zone, that is something we could do if it were just from, and I have to go back and look, draw it up on a map, but 1,000 feet from schools and not the parks could work. That could leave a lot of available space, or my recommendation was going to be that I was going to put in front of the council if it was parks and schools. I think 500 feet was probably going to be the farthest we could go that left, I guess in my opinion, enough room to put these facilities in. But if it is just going to be schools, it probably can be more than 500 feet if it doesn't include the parks. But again, this can go back to the council, and then I can sort of get my direction from them and coordination with all of you here.
When you look at the map, 1,000 feet covers most parks. It doesn't get that diameter to go further, but it does include the parks, most of them. And when we look at the numbers and you go back and forth, I think that that's probably the best starting point for the whole thing.
So then I have to ask another question to the solicitor, sorry. So does that include colleges and private schools, or are we only including the Lowell public schools?
The way I understood the motion, it would be Lowell Public Schools. But I guess,
Right, because we should include the private.
It was all schools.
so again, normally we don't have this piece in the process. I would go back to the council. No, that's fine. We're here and that's fine. It would go back to the council and then they would say, oh no, actually we want it to be inclusive of the colleges or whatever other schools, and I would make that adjustment for them.
Well, you're talking about charter schools and everything, right? Yeah.
Charter.
Yeah, in the university, yeah.
The Immaculate, I'm thinking the same
Yeah.
campus, right?
Yeah,
Are you
Non-public
assuming-
schools.
Right?
right.
Can I just ask all of you in this consideration, when you draw this map and you look at it, there are the experts here who know whether the people are gonna be able to get to the spaces. If it's 900 feet, right, like, can we at least use our brains and have a reasonable conversation with the experts to say, yes, it would make sense to put it here, even though it's 900 feet? Not 5 feet, not 100 feet, but
Well-
you're gonna make it so draconian. I just think about UMass. UMass as a school is half the city.
UMass is the first place that actually took down an encampment. UMass doesn't want it anywhere near them, in my opinion. And, again, it comes down to, if you go down that area, you look at Verizon just put multi-million dollars into a building on Appleton Street. Do you know they can't have a dumpster there because their trash company told them, see you later, because all the needles were going in there? Or if you go down another 100 feet down the street, there's another business down there that had 110 needles on the roof, and it cost them over $1,300 to get it
I'm not
removed.
disputing that. I'm just saying, when you draw the map out
Yep.
and you put the restrictions in, and you look at what's left over.
Well, that's why we have open hearings on it. So if somebody wants that, they can go there, just like you guys can share it to them and say, you come to a council meeting and you say it during a council meeting. Sharing it back and forth and having private negotiations with people back and forth is not open government.
Fine, I agree. That's fine.
So what happens is we have ordinances and you have public hearings and people show up from the DPH and they say, look, this works, that doesn't work, we need to go back to the drawing board. We don't negotiate in private without the public having a say in it. And even here tonight, it's kind of, iffy what we're doing. And we're just sitting here saying, let's have open government and look at this stuff. As you say something, the public's going to say something. So there's going to be people there that will, and I think you guys are the professionals, and I think most people in the city are rational, and I think it will work its way out as you guys have designed. And I thank you for your time, because I know that this is a hard conversation to have in public, and we would have rather had it probably separated with your group. But I think that what happens is if we bring something back to council brings it to us as an official document that goes to the council, and there's a public hearing portion, which you certainly can be emailed if you just say to the solicitor, could you email us that in the hearing date, and he certainly can get it to you. But to try to do a back and forth negotiations, that just isn't the way open government works.
I just want to say thank you for allowing us to be in this space, because we learn a tremendous amount from being able to witness this conversation. It helps us do our jobs better. It helps us do our work more responsibly to the city of Lowell and all the interest holders. So, thank you.
If you give me your number, I'll send all the parents who call me your number. This will be like 311 on steroids. I'm kidding.
Please don't be kidding. It's really useful for us. We, as state government officials, are responsible to every resident of Massachusetts, right? Every resident of Lowell, every resident of all the other 350 cities and towns, right?
Has DPH had any conversations? I see one of the huge pushes, one of the huge initiatives of the governor currently, especially, is kind of offloading surplus state-owned property. And if we have a shortage in longer term, where you mentioned earlier, say with $12 million, you could house 600 clients that would be offered that. Has that conversation happened on the state level? Because I know even in Lowell, and I think Lowell is bursting at the seams with social services, but other communities as well have surplus state-owned buildings. Has there been those conversations to try to repurpose them and invest some of the money that DPH might even feel is being wasted into, let's try a pilot program to do something in a community that might not necessarily been willing to do in the past?
Yeah, there's been a lot of looking at closed nursing homes and closed buildings. The problem is the funding and running it. So these programs are cost effective over time, but we would love to add more. We don't have any more money. So again, if I could save money on civil commitment or something like that, we could invest more money. But it doesn't, we're making a huge investment, and this is permanent. This money is not going away. We've made an investment over decades to do that. But yeah, we would love to do that. There's a lot of NIMBYism, and there's a lot of discrimination against people who use drugs. I don't even call it stigma anymore. It's just discrimination. People don't want even a sober home in their backyard. Lynn is trying to pull 7 sober homes that have had no issues from their city. And where are these people going to go? We need more residential facilities. We need more co-occurring residential facilities. These are things that we wanted to invest in, but yeah, it's the funding and being able to then support those programs, rehab them, put people in there, have people run them. But
that's a great answer. That's a great answer. One thing I'd like to add is to allude what you just spoke to, is that the suburbs don't want any part of this problem. We've seen it. We've seen, as a former businessman, I've seen cruises from Westford, Borica, drop off people at the shelter and just be on there for you. I've seen it. They've bus them in, they van them in. It's not fair. The cities share the burden on this. And so please, when you get into that, the footprint of rehabilitation needs to be expanded. And not solely on the cities, not just Lowell, the gateway cities all around the Commonwealth are getting hit really hard in this issue. Economically, and residents are deteriorate, quality of life is deteriorated, as I alluded to earlier. So please, we ask that you put an emphasis. The suburbs need to do their part too. On the overdose list that I used to get monthly, that we used to review monthly, every city in town was examined, believe me. Lowell was significantly less than 50%. Largely, they're coming from the suburbs. They need to do their part too. They own this problem too. So I'd like to express that for all of.
Completely agree. I live in a
Thank you.
gateway city. And so I completely agree that this is not for certain cities to be taken care of. So.
Thank you. Okay. Thank you, everyone. Oh, I'm sorry. Go ahead.
Yeah, I just wanted to thank all of you for your time and for putting humanization to the issue that we all talk about. It is a difficult conversation. I appreciate you all for coming as well. This was very educational, and I think that what we heard in the past was very dehumanizing. So thank you all for your time, your passion, your commitment, and for putting a better light to this.
Yes. Thank you. Thank you. Yeah, thank you. I had hand surgery, so I'm using my left hand. No, you know what? I want to.
Carrie's on leave.
Yes. Some doctor probably messed up her health.
I thought she quit anyway. I thought she quit.
She did. The next item on the agenda is the Tobacco Control Monthly Report submitted by Caesar, Program Director.
Yes, if you don't mind, I'd like to go straight for the hearings. So before you tonight, you have 3 establishments. They all sold tobacco to a minor doing compliance checks conducted on August 19th, August 25th, and August 29th this year. Each received a fine ranging from $1,000 to $2,000 for the offense. They have paid these fines. They have all received notifications about this hearing according to the USPS tracking system. So all of them received notification. I'm saying this because one of them is not here tonight. So I'd like to go straight for what happened. On the first one I'm going to call is New World Gas, located at 710 Lakeview Avenue. On August 19th at about 10:12 p.m., 10:12 a.m., they sold a pack of Marlboro cigarettes to the 18-year-old youth that you see a photograph in front of you. This was $15.20. That kid was not challenged at all. This was the first violation within the last 3 years, but there's been prior violations at that location. One of them was having flavored tobacco enhancers for sale on June 7, 2022, and also a sale to a minor back in May 29th of 2019. In the packet in front of you, as you're familiar with, there's a summary of what's going on, and then there's a copy of that tobacco permit application. Just want to call your attention to 2 items on the back of that application. Number 10 says, I'm just going to paraphrase, you can't sell tobacco to anybody younger than 21 in the city or in the state. And number 11 is very important. It says that each person has to be ID'd before they can be sold tobacco products. So checking ID is part of what the law requires. It's not just something that you do based on your gut feeling about somebody's appearance. So you must check everybody's ID. So there was this particular sale at that location. There's a history of other violations, minor violations, for which they have not received a fine. So they have Mr. Pradeep here to represent their store. Before I pass the word to them, I just want to say that my recommendation is a 3-day suspension to begin on November 17th of this month.
Good evening. Hello to everyone. My name is Pradeep, and I'm the manager at the store of Lowell gas station at 710 Lakeview Ave, Lowell, Massachusetts. I am not denying. I'm really sorry for mistake which was done by the person who was presented in the store. We personally, when we keep anyone to sell any stuff in the store, not only on tobacco, any store, like we sell the lottery and we sell the tobacco. Lottery cannot be sold under the 18 and tobacco cannot be sold under the 21. When we training any of the employee or any of the person who gonna work in the store, we always remind them, you can't sell the tobacco under 21. And we also remind them, if you gonna sell, it's gonna be the violation which is not good for the city, which is not good for the person who's gonna buy, which is not gonna good for anyone.
I'm sorry, I can't hear a word that you're saying. Can you speak up a little?
You can't really close the door. It doesn't help unless you close it.
Maybe ask the people in the hallway to.
Yeah. I'm sorry, my voice is a little bit down. I have a little problem. Sorry for that.
We can hear you better now.
Okay. So I was saying that the person who sold the tobacco, not only the tobacco, we always advise them, not only the tobacco, you sell tobacco under 18, under 21, you're gonna pay the fine, which is not good for the city, which is not good for the person who's gonna buy under 21. which is gonna cost a violation, which you're gonna pay the big money, which is not good. We advise any of the person who gonna take the training in the store, not only for the tobacco, not only for other stuff, like we sell the lottery, which is not gonna be sell under the 18. I know she has made mistake. I don't know what was the reason. When I asked the reason why you sell the tobacco under 21, why you sell the cigarette under 21, she was giving the statement by her saying that because of she was on the phone giving the order, she was receiving the deliveries, she was doing so many things in one time, and she was a little bit busy. I know she make mistake. I really sorry from her side. I will just ask you to forgive us, and we already paid the fine for that one. If you give us the chance, we're not gonna make this mistake again in the future. Thank you.
Thank you, sir. Anything else, Caesar?
I just want to stress what the recommendation is. A 3-day suspension began on November 17th. This is not the first time. They failed to ask for ID. That's why they sold to a minor. They know they can't sell tobacco to anybody under 21. If they had a bad procedure in place, they would have not sold tobacco that day. We checked several places that day. This was, let me just double check here. I believe this one was, on that day there were checked 20 stores. Only 2 sold tobacco to a minor, and this is one of them. So most establishments are doing the right thing because they're following better procedures. This one did not follow that procedure. If I recall this correctly, that woman that was working that store that day, she was not busy. There was nobody in the store when I walked in to confirm her description. She was busy doing other things in the store, but there was not a line of customers, nothing like that. So to me, this goes back to training. If he is the manager, he's responsible for training every single employee that they have, and not allow anybody who's not properly trained to sell tobacco until they're ready to do so.
Yep. So, sir, we appreciate your apology. I still, despite that, I'm going to make the motion to suspend you for 3 days, as we typically do in this situation.
Yes, for roll call. Second.
November 17th?
Yes, for November
I'm sorry, who
17th.
seconded?
Aaron?
Okay, roll call. Joanne?
Yes.
Bill?
Yes.
I'm afraid Kathleen. It's been a long night. I need a secretary, Aaron.
Keegan? That's my name, Keegan?
Starting the 17th for 3 days?
Yes.
All in favor?
All in favor?
All did.
Aye.
Thank you, sir.
Sir, just a reminder that the next time you came in, you know, the issue would be compounded, and we hope that you've educated your employee around and trained around the issue of selling to minors. Thank you.
You're going to receive a certified letter confirming the board's decision tonight, but just so you know, beginning on November 17th, there should be no tobacco at all anywhere on the premises. You have to remove it from the premises, not put it in the back. But the letter will say that as well. Thank you. Next is Lazy Bones, 189 East Merrimack Street, Lowell. They sold this pack of cigarette on August 25th. They received notification on the 22nd of October, according to USPS tracking system. There's nobody here representing that store tonight. My recommendation is the same as for the previous store, a 3-day suspension to begin on November 17th.
I'll make that motion.
Second.
Roll call?
Joanne?
Yes.
Bill?
Yes.
Kathleen?
Yes.
Aaron?
Yes.
All in favor?
Aye.
So it's the 11/17 for 3 days.
Yes. Next, we have Harry's Food Mart Mobile at 1460 Middlesex Street in Lowell. They sold this pack of Marlboro cigarettes on August 29th at just about 8:56 a.m. for $15.40. This is not the first time they sell tobacco to a minor. They had previous sales on May 16th, 2023, and also on March 2nd, 2022. This would have been their third violation within 3 years had it not been for 3 months. So it's a second offense within 36 months. My recommendation is a 7-day suspension, consecutive day suspension to begin on the 17th. Mr. Arnish Patel is here tonight. He's the manager.
First of all, I just want to thank the board.
Could you just say your name, sorry?
Oh, my name's Amish Patel. Do you need the address?
No, it's okay, I'll get it from you.
First of all, I just want to thank the board for being here and even wanting to hear us out. First of all, I also want to sincerely apologize for the incident that occurred at our gas station involving the sale to a minor on August 29th. I recently became a manager here about 7 months ago. I take full responsibility for what happened and understand that selling to a minor is a serious violation, and we do not take it lightly. This was an honest mistake made by one of our employees, but ultimately, as a manager, I know it is my responsibility to make sure all sales follow the rules and regulations set by the health board. Since the incident, we have taken several steps to make sure this never happens again. I have retrained all employees on proper ID check-in procedures, including implementing scanners and LED lights. I've implemented a strict policy that requires everyone to check ID regardless of age. I added signs and reminders near the register and even on our radio system. And we also keep a written log of compliance checks and reminders at every shift, so whoever comes on. I truly regret this incident and understand the importance of protecting minors. I'm 23, so I was a minor 3 years ago. My little sister, she's a minor right now. And I went to Lowell Catholic. I graduated UMass Amherst, so I do understand how important it is to protect our community and protecting our minors. I do understand that. I want the court to know that I take this as a learning experience, not just for my job, but for my growth as a manager and as a person. We are human and make mistakes. I'm not using that to justify this at all. I'm just saying that. But we have learned from it and have taken it as a serious lesson. We hope our actions since the incident show that we are committed to full compliance going forward from here on out. I respectfully would want the court to reconsider the 7-day suspension. The board to reconsider. And I also want to share why it is so concerning to us. I grew up in an environment where I never followed money, neither has my father, and that's who I learned from. We always followed our work ethics. And it's not for financial reasons that you may think like, oh, the only reason he's saying this because financially they want money. That's not the reason. It's just in terms of our customer trust. I've been at this establishment for the past 10 years, but I grew into the manager role about 7 months ago, like I said. And in that time, I've built personal relationships with many of our regulars at a point where we know them by name, we know them by what they want, and sometimes I even charge them on a weekly or monthly basis, just because they come in so regularly. But what I'm trying to say is that they count on us for reliable service. If they come in and learn that we can't sell tobacco, they may start going somewhere else and may not come back even after the suspension ends. And again, it's not for money reasons. It's for that connection that I've built with customers over the years, where a lot of them have impacted me in the way I grow and my outlook on life. I honestly wouldn't be here. Back like years ago, I wasn't very outgoing, but because I started working at this establishment, it did help me with personal connections and how to build these relationships. The store is a part of the community, and I truly care about maintaining the trust we build with our customers. Again, just to say again, this is a mistake on my part, and I do completely understand and realize that, and I've put in systems to make sure this never happens again. And I just want to thank you for hearing me out, and I'll trust that you guys have been here longer than me. I trust that whatever decision you guys do, I'll trust whatever you guys do.
Is it the same owner? You were here for 10 years, but now you're a manager as when the last offense occurred?
Yes, it is the same owner.
Do you remember the last offense? Were you involved
I
with
wasn't
that?
there. I was at school. I
Okay.
graduated a year and a half ago.
But it's the same owner?
Yes.
So, Caesar, the difference between the 3 days and the 7 days is because
Second offense.
It's because it's a second offense within
you're
36
not
months.
considering it a third offense. It's a second offense.
A second offense.
It's technically a second offense.
It's technically a third offense, but not within the same 36 months.
Right.
Your speech is very eloquent. You're going to go far no matter what. This is part of your learning journey.
Exactly.
We hold your owner responsible more than even you. It's 3 in basically 3 years. Can't let that go, sorry. I can't anyway. So I'm going to make the motion. I would actually suspend your establishment more than 7 days. I treat it closer to the 3, but for the sake of consistency, I would make a motion to suspend you for 7 days, starting on
17th of November.
11/17.
You weren't selling cigarettes 10 years ago, right?
No.
Just wanted to make sure.
No.
Yeah.
I worked it was more just like filling up coolers and stuff and learning everything else, like candies and whenever you get deliveries, put them away. Yeah, worked in all throughout high school as well.
Are you related to Harry?
Yeah.
Harry is the owner.
Harry should be here. And you let the owner know the third time, if you come back in the next year, it's gonna be 30 days?
30 days.
And it will be, like I said, we have zero tolerance, generally speaking. Third offense in just over 3 years is really hard to overlook. And again, we don't hold you responsible. Sure, you do great. Your owner needs to do something different. Maybe hiring you will be the best thing that happened to him. Hopefully it will be.
Do we have a second for the motion? Yes. Kathleen? Joanne?
Is
Roll
this,
call. Joanne?
yes.
Bill?
Yes.
Kathleen?
Yes.
Aaron?
Yes.
All in favor?
Aye. Thank you for coming and thank you for your honesty.
Appreciate it.
So you're going to get a certified letter explaining the board's decision. Just a reminder, remove all tobacco products from the premises as of the beginning of your business on the 17th. There should be nothing on the premises. I'd like to thank the board. Thank you.
Thank you, Caesar. I liked that kid.
He's gonna do great. He'll be fine. He's not,
You should buy the store.
he should buy the store from Harry's, right.
They should invent like an ID checker that you put right on the glass cabinet. You can't even open the cabinet to get the cigarettes.
If
and
you
so
let
put-
him off, next minute, he would just get somebody else. Who knows, he'd send somebody else with the same story.
I know.
It's not me,
I'm a sucker for a good story, though.
Well, that's a guy, kid, you know, will succeed. He'll be fine.
He's also right, he's gonna do well.
He'll do well.
The next item on the agenda is the monthly development services report submitted by Matthew Sheehan. Hello.
Everybody. As you can see in the report in front of you, we had, for this reporting period, we had 5 new establishments that opened in the city. And we also had 5 establishments that failed in the city. As you can see in the report, all the failures were for mechanical reasons, whether it was an expired hood system, expired answer system, expired fire extinguishers, but all 5 failures have since passed their reinspection. And what I will draw your attention to is the food trucks from the school department are in compliance.
Yahoo.
So the entire school department is in compliance, and myself and the team will be, 6-month time, so we'll be there March, because we started in September, so we'll go back out in March. And that's.
Hey, so I just have one quick question on your report. There was another one of these, it was February 24th. Or is that just another typo? Is somebody putting one typo in each time just to see if we'll catch it?
No, so
Perperia Indian Cuisine, it's on the first page near the bottom, on Westford Street, 20 February 24.
So it's me. I don't excel in I. So in like superhero stuff, like I'm Superman because Superman's cool, and Excel is Lex Luthor. Like or Kryptonite, whatever you want to be. But I will say that the women that I work with in the office, all my head clerks are amazing. So every time I yell at somebody's name, they come right over, and it's a learning experience with Excel. But we're getting there.
Got it.
So it hasn't been a year and a half since?
No, absolutely not.
Okay.
No.
That's the answer
I
to
have
that
a
question.
question on the Ansels, just, 'cause it just seems like that's a lot for one report. The last time I think we saw that many, there was like an issue where Ansel was like backed up getting out to do them. Is there any issues with that we know of? I know
there really
COVID
isn't. I
caused some
think
stuff, but we're years from
it's
that.
more of a cost factor. They try to stretch it out as long as they can.
Gotcha.
And I mean, I don't fault them for that, but, every food establishment in the city knows that we come in every 6 months. So they really need to adhere to the tag that's on there because the answer system's only good for 6 months. So my opinion is I think it's really a cost factor for the establishments. They're just trying to stretch it out as long as they can, but.
You should treat it like the inspection stickers for the car. It doesn't matter when you get it done, it goes back to the original date, so you're not stretching it out.
Yes.
They do that now.
Yeah.
There we go, we want to
My
make an
husband
ordinance.
used to try to get an extra month.
Send it over there.
Yeah.
I used to do it every year, yeah.
See you guys. Any questions, comments? We're good.
Thank you, everybody.
Thank you.
Thank you.
Thanks for waiting.
Happy holiday.
Thank you.
You too.
The next item on the agenda for review is the Pride Star Trinity overdose report. I think, anyone have any questions on that?
Next,
Motion to accept?
we don't have to make a motion,
Okay.
for that, but yeah,
Oh, we don't?
I don't think so. Oh, then I'll second it if we do. Next.
The next item on the agenda is the Cashins and Associates Air
Great
Quality
report,
Report.
great reports, we don't need to comment on
I
that.
think we missed the, is next on the list actually the.
Oh, the calendar's
the
on the list.
calendar,
Sorry, yeah,
And I
you're
don't
right.
think it was written on the.
Oh, it's not on the
yeah.
agenda.
The secretary was noticed.
I didn't get a calendar.
Oh, you did?
It was in the,
Here,
it was in the
I
pack.
have it online.
Yeah,
I
it's
have it in the
online,
online
yeah.
one.
Oh, okay. So it's basically just the first Wednesday of every month. So is everybody okay? But I just need to book the rooms.
Yep. Any problems? No? Okay.
I have my usual
Right.
December
December, so you
conflict.
won't be here next
No,
month. Okay.
other than that.
Yeah,
Okay.
So I'll book the rooms.
Okay, we all set on that? The next item is the indoor air quality report, and everything looked good except for one situation
Yeah.
Corrected.
Yeah, there was.
that was corrected.
There was one situation with the Tide Pods or Downy Pods or something.
So, but it reminded me that this was an attempt to deal with a rodent situation, and so please tell me that someone did some educating of the staff about how they report the
Yes,
rodent
which
situation.
we should have kept Mr.
Oh, yeah.
Sheehan here for that, but I did follow up with Mr. Sheehan, he followed up with the pest control, so that was all done. I'm not quite sure if any mice actually were seen, there wasn't really a real issue.
Okay.
And then there was a thing saying that the floor had to be cleaned, so I had to reach out to make sure that the floor actually was cleaned. It created a lot of work for us.
I'm just terrified that my laundry detergent actually has volatile compounds in the air.
Well, imagine.
Breathing the
Well,
scent
all
of
your
it.
laundry
Oh, yeah.
detergent
Right.
does.
I wonder if you did a
Right.
reading right around me right after I took my thing out of the dryer.
Right, yeah.
Yeah, smells like clothes.
So my deodorant.
Who would have thought,
Anyway.
right?
Well, rodenticide is moving strong through the state. We had a big showing. That was really good. They really liked that we had some data from the full school scope from when we started to ended, so that was good.
Okay, and the next item on the agenda is the departmental divisional reports. So,
You know what would be great now is if Frank were here. We had a Frank. Go ahead, sorry.
I was gonna say something, but I'm not going to. The
I just had a
service
question
report.
on the Lowell co-op overview.
Yes.
They talk about 70-plus follow-ups linked to LPD Trinity medical incidents under client services.
I think what they're talking about there is
Right.
their overdose follow-ups, but for some reason they wrote it that way, I'm not quite sure why.
Okay, I didn't know what it meant.
Yeah, because this doesn't say any follow-up. This,
Linked to.
Does it mean that the police department or Trinity are notifying them of patients that they bring?
yeah, so what happens is every day they go through all of the police reports, and they go through all of the Trinity and Pride Star reports, and then that's how they do their follow-ups for anybody who's received Narcan.
Oh, okay.
So they worded it differently. Caught me off guard too.
And in terms of the comment about VinFin, I'd be curious if VinFin has a comment about people leaving their facility and shooting up in the streets after they leave the facility, which was alluded to by the counselors.
No, so I think what they're saying is VinFin bought the old V&A on the corner across from the Dunkin' Donuts.
Yeah.
And what's happened is we've pushed people out of a certain area, and then we push them out of Jay's, and now they move to another area.
Okay.
So we're just constantly moving people.
Yeah, there's a big, like, grouping of people always right there.
Right there,
Yeah.
because VinFin's right
Yeah.
there.
Correct, and VinFin bought the old V&A on the corner, so people now have moved to a different area. Yeah, the co-op was there today with LPD,
Oh, yeah.
so the co-op was there today.
Lisa,
There's definitely drug activity there, though. I've seen people like buckled over, standing and sitting, yeah, definitely.
Yeah.
So I don't think that comment was far-fetched by that person.
Yeah, so they're in the, the Church Street area there, and behind now is where they are, but they've been moved from Jay's over.
Yeah.
From Jade?
Jay's.
Oh, Jay's.
Market.
And then just what is a Vinfin situation table? Is that just, was a meeting and discussion?
Yeah, so what happens now is there's a group of people that get together one day a week, and they can bring a client together, and they don't say who the client is, so they could say like, client AB, and they have quite like 10 service providers, and they'll say this is a very difficult person, so they all put their heads together to see what services they could bring for that person. If they can't figure out what to do for someone, or if they need services.
Like a team meeting.
Yeah, like a team
Yeah,
meeting,
yeah.
but outside services, but they haven't signed a contract to speak about the person, so they don't say who the person actually is.
There's the youth outreach specialist, was that our grant-funded position from before? Did we get grant money for it, or it's just?
That's through the police grant, through the post-up grant, so that's through the police grant, but it sits at the co-op, so it's under my supervision. So it's the police grant that funds that.
Okay.
And do you have a new school nurse coordinator?
Okay, so,
Sorry, I'm jumping.
are you ready?
Yeah.
Are you ready?
You get some salaries?
Ready?
Salary of 0?
Don't say you're gonna be the new school nurse
No,
coordinator.
the posting comes down tomorrow, so I have one more day to apply. So, that position will come down tomorrow. We have an interim school nurse coordinator. We have a new public health nurse, hope I don't jinx myself, starting on Monday. We have onboarded 3 school nurses this month.
Awesome.
We have 2 more school nurses onboarding. We have onboarded 2 substitute nurses, and we have 1 more offer out, and we have 2 more offers out to school nurses.
Oh, good.
Awesome.
So you were really down with the school nurse numbers. it
We
sounds
haven't
like.
hired a nurse in 6 months.
Oh, that's crazy.
So those are backfilling positions, sort of.
Well, we had resignations over the summer, so it
Mhm.
was
Yeah.
a little difficult. And then, so Hope actually Hope gave you numbers, but then there were, Maven's system was down, so I just gave you the public health numbers, late. I think they were on your table, so they were a little late, and then I emailed them to you.
Yeah, I saw them on the email.
Okay, and then, so, next week we have unwanted medication and sharps disposal day, 10 to 2 at the senior center. So anybody wants to do a drive-through and do unwanted medication disposal day. We are just finishing up, flu clinics. They gave, I think it was on here, they gave like 260 vaccines already, so quite a few. And they will do homebound patients now. So if there's any physicians at Circle Health that has homebound patients, they can call the health department.
You should know about it.
Yeah,
I'll mention it, but.
yeah, you can mention it. VNA has called us, and VNA will do them as well, so if anybody's VNA. And then, I did talk to the VNA supervisor, so if they go out to do one person, and then there's a second person that doesn't have VNA services, I said, call us for the second person, if it's the second person, so, I did let them know about that.
Great.
I think that's it.
Move to adjourn.
Are you, Madam,
I'm done. Second?
all those in favor?
Thank you.
Thank you.
The boss is texting me like, what the
Oh, jeez, yeah.
Sorry
Oops.
about that, sorry about